Welcome to the Center for Health Affairs Board Education presentation, Through Frank's Eyes, Hospital Care from a Patient Perspective. This presentation is based upon the Center for Health Affairs issue brief by the same title, which can be found on CHA's website, www.chanet.org. All issue briefs, as well as their corresponding PowerPoint presentations, are available on our website in the Publications section. This issue brief, originally released in May 2008, uses a hypothetical patient named Frank to examine a typical patient's journey through the hospital. For patients, especially those unfamiliar with the system, a trip to the hospital can be overwhelming, especially considering the increasing demands and shrinking resources hospitals encounter every day. Providing excellent patient care in this environment can be a challenge. So what does a typical experience look like? Frank, our hypothetical patient, attempts to answer that question. First, let's take a look at what happens to Frank. His journey starts when he stumbles in his driveway and hurts his ankle. He decides not to go to the hospital at first, but after a long, painful, sleepless night, he changes his mind and heads to the ER. Not only is Frank in pain at this point, he is also tired and hungry. Once Frank makes it to the emergency department, he rests in the waiting area and notices a number of things. First, it takes longer than he expected to be triaged and called to a room. He sees other people who are called ahead of him, despite the fact that they arrived after him. He also notices that the waiting room is crowded, and that a lot of people sitting there with him do not seem all that sick. He watches the nurses, who seem very busy, and notes that no one stops to check on him during his wait. In addition to having to wait longer simply because there is a crowded waiting area and numerous people needing care, Frank has to wait longer because his injury is not life or limb threatening. Though Frank understands the situation, he can't help but feel frustrated that he will have to wait longer before he gets relief. Finally, Frank is called to his own room in the emergency department. He waits a long time to see the physician assistant. Frank, who is normally fairly upbeat, begins to get frustrated because no one will bring him food when he tells them he is hungry. He receives lab work, a system review, and is sent for an X-ray. He is also given pain medication. Soon after, he learns that he will need surgery for his unstable fracture. While Frank is waiting in his emergency department room, he goes through a host of emotions. He is frustrated about waiting, irritable because he is hungry and his situation is stressful, surprised that he will need surgery, and overwhelmed that his injury may cause permanent changes in his life. The orthopedist on call agrees to add Frank to his schedule and assesses him between cases. The orthopedist adds Frank's surgery to the end of his list of scheduled surgeries for that day. Again, Frank waits a long time to be assessed and to have his surgery. Since there were no beds available in the short stay area of the hospital, Frank spent his time waiting in the emergency department. Frank's surgery goes well and he is released after a 23-hour observation. The morning following his surgery, Frank tries to be pleasant, but after 2 sleepless nights and the stress of the situation, he is less than cheery. There are a myriad of factors that contribute to a patient's experience in the hospital. Though no two hospital experiences will be exactly alike, there are a number of similarities that will likely be encountered regardless of the situation. Frank can serve as a good example. Just like Frank, many patients spend a lot of time waiting. Frank also noticed that the nurses seemed very busy. Many hospitals struggle to fill vacancies, which can make it hard for the available staff to spend a lot of time on patient requests. These same staff are also often charged with taking care of at least a portion of the administrative and regulatory responsibilities so prevalent in a hospital setting. In terms of wait time, the statistics on this slide speak for themselves, with the average amount of time spent in the emergency department creeping upwards, up to an average of 3.7 hours in 2005. Wait time is an issue that every hospital must be aware of. Wait time often results from the simple fact that sometimes there is more demand for the resources of an emergency department than there are resources to give. Emergency departments also sometimes experience unexpected busy periods, which can lead to increased waits. One study that examined hospital wait times made some helpful and interesting findings. The study showed that patients who received no information about wait time tended to be more dissatisfied than patients who received updates about delays at regular intervals. In fact, when patients received regular updates, they were more satisfied and understanding, even if their wait time was longer, versus patients who received no updates and had a shorter wait. One common reason behind long wait times is overcrowding. Between 1994 and 2004, the annual number of emergency room visits grew from 93 million to 110 million, an 18% increase. During the same time period, the number of hospitals offering 24-hour emergency departments decreased by 12%. Northeast Ohio is not immune from these trends. Between 2000 and 2007, our area lost 4 hospitals that provided emergency services. While Frank's wait time may be distressing to people in the healthcare industry and to Frank, it is not unusual. The most common factor in crowding, according to one Government Accountability Office study, was inability to move patients to an inpatient bed once the decision to admit them had been made. In addition to boarding in the ER, patients are sometimes put in hallways or other treatment spaces. EMTALA, or the Emergency Medical Treatment and Active Labor Act, ensures that no one who needs treatment will be turned away from an ER. Though it was designed to help patients, EMTALA can have the unintended consequence of leading to increased unnecessary usage and overcrowding, and also to more patients who are unable to pay the hospital for the services they receive. Though wait time is something that is plaguing the nation, the news is not all bad, at least not for Cleveland. Northeast Ohio hospitals tend to move people through their emergency departments faster than other hospitals across the nation, according to the Center for Studying Health System Change. Possible explanations include added space, renovations, and greater efficiency. Another possible contributor to the positive trend in Northeast Ohio is that between the years 2005 and 2006, as well as between 2006 and 2007, there was a 1.3% decrease in the number of ER visits to CHA member hospitals. The range and number of people required to successfully populate a hospital workforce is staggering. In addition to the professionals listed on this slide, hospital administrators must ensure that the hospital has adequate staff in areas such as food service, administration, billing, security, and facilities, just to name a few. Filling each of these staffing areas can be a challenge for hospital administrators. Nursing is one field in healthcare that is particularly challenging for administrators due to a nationwide nursing shortage. At the same time that administrators struggle to fill nursing vacancies, the number of demands placed upon nurses grows. In one study of patient satisfaction, more than 25% of respondents reported that there were times when nurses were so overworked that they were too busy to take care of them. Frank's care was affected by these challenges during his time in the emergency department. Frank, who wanted someone to check on him and bring him food, did not know that in the room next to him was an 80-year-old woman who was having difficulty breathing and required immediate emergency care. Frank's nurse rightfully stayed with this woman until the medical crisis was mitigated. Nursing is not the only field with troublesome vacancies. Allied health professional positions such as CT technologists, radiology technologists, and physical therapists can be as hard or even harder than nursing positions to fill. This is true for CHA hospitals as well, who averaged an 8.9% vacancy rate in a recent survey. Ensuring that hospitals are adequately staffed with physicians to cover the needs of the ER has become an issue for many hospitals. Some hospitals have changed their structure so that private physicians are employees rather than independent agents. Others still have reluctantly resorted to paying physicians for their time in the ER. These new arrangements have made it all the more challenging for hospitals to stay financially viable. The first step in treating a patient is gathering information about who he or she is. This occurs at initial registration. At this time, a patient only provides the most basic information, like name, address, and complaint. The rest of the registration, such as insurance information, will not be gathered until after the patient is in his or her room and has been seen by a physician. This ensures that EMTALA rules are being followed. Regulatory responsibilities for many patients are relatively few. However, Medicare patients are asked to sign and review 8 different documents for one visit to the emergency room. Following administrative and regulatory requirements can be a daunting task for hospitals. However, it is pivotal that these regulations are correctly followed and documented because they are required in order for a hospital to receive Medicare and Medicaid payments. In Northeast Ohio, these patients account for 49.6% of patients in 2004. With such a large share of payments coming from these two sources, choosing not to follow their requirements is not an option. The rules regulating Medicare and Medicaid contain more than 130,000 pages, a volume 3 times the size of the IRS code and its federal tax regulations. From the hospital's perspective, there is a great deal of time spent on administrative and regulatory requirements. With almost 30 different agencies involved in hospital regulation at the federal level alone, it is no wonder so much time is devoted to documentation. All the mandatory paperwork cuts into time that would be spent at a patient's bedside. For instance, in the ER, every hour of patient care requires an additional hour of paperwork. A few weeks after Frank returns home, he receives a total of 12 envelopes in the mail. Though he is familiar with the concept of billing, he is unsure what to make of all these different documents. He calls the hospital's customer service line to help him figure it out. Billing for a hospital visit is not as straightforward as billing in most other industries. Whereas most other billing scenarios are rather intuitive: provide goods or services, bill for cost of goods and services, receive payment for goods and services, there are many more variables to consider in providing the service of hospital care. Hospital or facility charges include room, board, and continuous nursing care. Ancillary charges are another set of charges that refer to items such as radiology, pharmacy, and laboratory services. Since the physicians and specialists are often not employed by the hospital, they provide yet another set of services which are also billed separately. With so many elements coming together to provide care to a hospital patient, it is not surprising that the process to bill for that care is so complex. From the hospital's perspective, gathering the information required for billing requires diligent record keeping by each care provider. This information is recorded on a patient's chart. The chart is then given to a medical coder who reviews the record, assigns the appropriate code, and transfers the information to a billing form. At the same time, the challenges that patients face present problems for hospitals as well. While patients try to sort out their confusion or work through insurance denials, the hospitals are stuck waiting to be paid for services. With the faltering economy and insurance companies increasingly putting more payment responsibilities into the hands of patients, the situation is intensified. It is important for patients to have at least a broad sense of the factors that converge to provide patient care. The task of educating patients about the nature of their care should not rest solely on their care providers. Patients heading to the hospital should bring with them basic knowledge of their own healthcare situation, such as medical history, allergies, medications, and insurance information. But being an empowered patient means more than just being prepared, and it yields results beyond keeping hospital experiences orderly. When a patient understands the constraints under which physicians and nurses must work, he may be more likely to proactively inform his care providers of changes in his condition, rather than passively waiting for someone to check on him. In some cases, these types of actions can make all the difference in outcome. With all of the challenges facing hospitals today, the mission of providing excellent patient care is not an easy one. Viewing a hospital experience from the eyes of a typical patient enables us to see that these challenges do not go unnoticed. Their results are felt by everyone in the system, from healthcare provider to patient. This concludes the Center for Health Affairs Board of Education presentation, Through Frank's Eyes, Hospital Care from a Patient Perspective. Thank you.